morning, everybody. Thanks for joining us to the 12th Empowering Seniors event, sponsored by our Commissioner, Rebeca. Even the pandemic could not stop us, right? We've been doing this for 12 years, and we just made a little switch. We're live broadcasting online instead of an in-person, but here we are with all the fun information and our favorite Ask the Doctor session. We have three esteemed panelists today. Dr. Bassam Ghabach, he's the Chief of Oncology at JPS Health Network. Dr. Ghabach, say hi.
Hi, everyone.
Yeah, thanks for joining us. And we have Dr. Rebeca Sharp, an internal medicine specialist. She's with the Texas Health Harris Methodist Hospital, HEB. And good morning. And we have Dr. Lesca Hadley. She's a assistant professor or associate professor at the Department of Geriatrics at the UNT Health Science Center in Fort Worth.
Morning.
Good morning. Thank you all three for joining us. I know your days are busy, and we appreciate you spending the time with us to answer questions that people have pre-submitted. We're real proud that our seniors, sometimes who are called technologically challenged, they're actually doing a great job of getting us all the questions. And we're going to record this session and post it on the website as well. That way people can watch it later if they couldn't join us live. But we have a lot of questions. Some may fit with your specialties and some are general. So do the best you can to answer, and we'll get going. So let me ask you some questions here that just rolled in. So somebody asked that their husband was just diagnosed with a brain tumor, and he refused to talk to the spouse on the phone last night. Is behavior change expected? Make sure to unmute yourself if you're going to answer.
Yeah, I'll take this one. With the brain tumors, because depending on where the location of the tumor is, that can significantly affect the behavior of someone. So we don't expect them to always make rational decisions or choices. So it is really important to try to seek medical care for these patients. Easiest thing to do would be to call 911 if a patient refused to go to the doctor, just to have a medical professional assess them at home and see whether they really need to go in or not.
Excellent. So there's another question, very general. So if your doctor makes a referral saying, okay, go to this doctor for whatever reason to get checked out, different specialist, and you either don't like the doctor or don't want to go to that doctor, is it okay to ask your doctor to change the referral to a different physician?
I can take that one since I refer away. When we choose a doctor, we try to do it matching what we think would be the best, also insurance-wise. We're finding that with limited panels in different insurances, we may want to choose one doctor for one thing and another for another person just because they have different insurances. But listen, this is a partnership. And if you have somebody that you feel that would best work with you, then let's go for it. Let the doctor know. Listen, I heard good things about this doctor. Is there any way that I can see him? And then we can look and see, oh, well, he's in your panel or he's not in your panel. That's the reason why. But there's many, many doctors and many, many options. And this should be a two-way conversation.
Absolutely. Thanks for saying that, because people feel sometimes shy of asking their doctor a question. And doctor is your guide, right? Your primary care physician, especially, is your guide into the healthcare world. Use them. Ask the question, like, I don't want to go here for whatever reason. Can we go somewhere else? I don't think there's anything wrong with that. But thanks for empowering our seniors to, be able to do that. So another general type question, and maybe either one of you can answer, are varicose veins ultimately going to affect the heart if untreated? I don't know. I mean, usually cardiology folks might answer that question, but either one of you want to venture a guess on that?
Well, usually varicose veins do not affect the heart. They are peripheral vasculature. What the heart can make it to where you have swelling, and varicose veins can make it to where you have swelling. So when you have swelling on your legs, you may want to investigate what's the cause. But if you have valves that are insufficient, and you stand for a long time on hard surfaces, and you have a lot of salt in your diet, you could have swelling in your legs because of the insufficient valves. But then you're always afraid that it could be because of congestive heart failure, or where your heart, which is a pump, is not doing the job like it should, and things could be backing up to your legs. So I guess the question is, if you're concerned that the swelling in your legs, whether it's due to varicose veins or the heart, it is best to go to your doctor and have them evaluate it.
Thank you. So Dr. Hadley, let me ask you this. So you're an associate professor in geriatrics. Most folks do understand that's senior medicine. But what can you explain us? What do people who specialize in geriatrics do? And what kind of clients come to you for what conditions, like, versus going to a primary care doc? When would they seek care from a geriatric specialist?
Just so that everyone knows, geriatricians are trained in family medicine or internal medicine for 3 years. And then we do an extra year of training just in geriatrics. And we take a test following that year just over what we've learned for geriatrics. So we do have specialized training in caring for the elderly. Many of us do practice primary care, and we really see that as part of our passion in geriatrics. If someone has a particular problem related to being older, such as having memory loss, falling, having trouble with many medications, taking at one time, or other what we call syndromes, which are just our collections of problems that go together, and the elderly, those are times when it's especially good to see a geriatrician.
Thank you. And are there any
so
examples?
We serve as
Are there any examples of
we serve as primary care physicians.
I think we're having some internet slowness there. So let me retry the question.
Yeah.
Are there any examples of conditions where people specifically seek care from a geriatrician instead of going to a primary care doc?
Memory loss tends to be one in particular, where family members will bring their loved one to a geriatrician, because often memory loss, as well as other things that go along with it, like weight loss, can be caused by many different problems, and having a geriatrician who is trained to see the overall picture can help sort out what's happening to that person.
Excellent. So let me switch gears. So I know that Dr. Ghabach is the Chief of Oncology Services at JPS, but what kind of cancers do you deal with in your cancer center? What is available in terms of services, and what are the common things that you see in your practice?
Yeah, so in my personal practice, I see mostly lung cancer and head and neck cancer, but I also see a variety of other cancer at the same time, but these are my two main focus area. What we tried to do since we moved to the new cancer center on 8th Avenue, which it's almost 18 months ago now, we tried to bring as many services as possible into one building to allow the patients to have a more comprehensive visits. So we have general medical oncology, we have radiation oncology, we have neuro-oncology, which specializes in treatment of brain and central nervous system tumor. We also have breast surgery, surgical oncology. We also have the ear, nose, and throat specialist also see the patient along with us. And we have several visiting doctors that have clinics at the cancer center 1 or 2 days a week. Like we have a neurosurgeon come in So if we have somebody with a brain or CNS tumor, they'll be able to see the medical oncologist, the neuro-oncologist, the radiation doctor, and the neurosurgeon, ideally on the same day. We also integrated palliative care into the cancer center. So along with medical oncology, we have them see palliative care specialists, which are really important in controlling the symptoms of the cancer and helping the patients navigate their journey. And last but not least, we have all the support services like social worker, nutritionist, psychologist present at the same building. So we try to have minimize the patient's visit, try to lump as many visits as possible together and make it easier for our patients.
So let me ask you a follow-up, especially since you brought up palliative care. A lot of people, when they hear that term, they automatically think, oh, well, this person's got a very serious illness and they're going to die. Is palliative care only used for end of life, or are there other situations where patients could benefit from that palliative care?
Yeah, no, we actually see palliative care as an integral part of the treatment of cancer patients. So they help us with symptom management, patients with pain, nausea, fatigue, all these side effects that could be from the cancer or for the treatment themselves. Palliative care doctors help us manage these. And they also help with advanced care directives, planning, living wills, all these other issues. There's actually been studies that show that patients with advanced lung cancer who see palliative care doctors along with their medical oncologist actually live longer. So their overall survival is improved by seeing these doctors that help manage the side effects of the treatment.
So could you explain to us then a little bit of a difference between palliative care and then end of life care or hospice? I mean, how does that sort of separate, but they kind of flow together? How does that all work out?
Yeah, so end-of-life care or hospice care is the service that's available to patients with advanced medical conditions where we do not have any active treatment that are going to be meaningful for them. So the role would be to allow them to live whatever times they have, being comfortable and controlling their symptoms, and avoid having them to go to the emergency room to seek care for any medical problems they have. Palliative care is more an all-encompassing specialty, so they focus on controlling the symptoms of the disease, and they can help the patient transition to hospice when that time comes by. But they're not only focused on the hospice care.
Excellent. Well, thank you. So I have some other general questions that have come in, and so see if either all three of you or any of you can answer those. There's a question about asymptomatic inflammation. So maybe Dr. Sharp or Dr. Hadley, either one, if you've had any patients, is there any testing for asymptomatic inflammation? Patient has no infection, no known chronic conditions that might cause the inflammation. And they're asking about a couple of tests, HSCRP or LPPLA2, and would these be useful in determining a future risk of a cardiovascular event that may be aggravated by a hidden inflammation? Very technical.
Well, I can, I can defer to the geriatrician, but CRP, even though the specific CRP can be elevated for an inflammation that is not cardiac related, okay? Even though it's supposed to be more specific. The other one I am not too familiar with, you can have inflammation for many reasons, allergies, bursitis, Hashimoto's can cause inflammation. Mm-hmm. So sometimes if somebody feels inflamed, that's just such a difficult term for us. It really, it's something that we have to see. We have to do what other symptoms do they have, the heart, if they are concerned, what's their cholesterol, what's their blood pressure. We don't use one test to tell us risk of heart disease unless that test would be a cardiac cath. I mean, that would be the gold standard, right? But there's not a lab test per se that would say, okay, this is it. So it's a picture. You need the whole picture.
Absolutely. So let me ask you, because we try to ask this question, but the panelists were specialists, and now we have an internal medicine doc, so maybe this will be up your, a bailiwick here on annual Medicare wellness exam. So the question is, how do doctors conduct the annual Medicare wellness exam so it is a meaningful encounter with a patient who has no health issues and only sees their primary care doc once a year? And their concern is, according to Medicare guidelines, Medicare even says that the wellness visit is not a physical exam. So how do you assess the patient's health by just asking a Medicare list of questions and then make recommendations based on that? How do you turn it into a meaningful encounter with the patient?
All right. Very interesting question. When Medicare started allowing us to do preventive, what they call Medicare preventive, we were shocked that it had nothing to do with actually touching the patient or listening to the patient. So I'm not privy how they came up with this line of reasoning, but what you do in the exam, it is about depression. There's a depression screen that we do. It's about falls. You also are supposed to ask whether they have a living will, which is such an important thing, advance directive to physicians. And I know that the geriatrician will agree that we would want to know, and the oncologist, what would you want us to do in the event that something happens to you? Guide the doctor. Don't give it to your family members to try to make those decisions. Sometimes they don't know what you want. So we agree with that. So a living will, depression, falls, we're supposed to ask for falls. In the initial Medicare exam, we also do a vision test, and we also test for memory. There is a mini mental exam that is involved with it, one more complex of 12 questions and one of just two questions. Most of them involve drawing a clock, the face of a clock. And that's it. How can you make that meaningful? If you don't know the patient well, then you can see a decline in their mental status, in their decline in their functional ability, and then you can come in and suggest things like physical therapy. So the questions are, can they dress? Can they walk? How far? Can they drive? Can they write a check? Just those kind of functions. But you're right. The preventive exam does not involve an actual physical exam, but it is investigating activities of daily living, mental capacity, and planning for care after you turn sicker.
So, as you know, COVID-19 has been around for several months and has made life complicated. And as if that wasn't enough, we've got flu season starting. October 1 is the official start of the flu season. Already there's been, news coverage about flu in the community and the vaccine. So what advice would you give our seniors how to navigate this double scenario of COVID-19 and flu, and what should they do to stay safe?
Well, thankfully, what protects you from COVID will also protect you from the flu. So doing all the things we've been taught to do for COVID, such as washing our hands often, being careful about being close to people who are sick, avoiding crowding situations, and even wearing the mask. All these things will also protect us from the flu. More than anything, though, especially for seniors, I highly recommend they all have a flu vaccination because flu vaccinations will prevent the more severe cases. A pneumonia vaccination can also help prevent complications like pneumonia, which can often follow a flu.
Absolutely. So let me ask a follow-up on the flu vaccine. A lot of times, there's a lot of media push, get the vaccine early. Is there a time that's too early? I mean, now we're in October, so, there's a lot of vaccine available, but there was a lot of talk like late July, early August, let's get some vaccine. Is that too early, or what do you recommend to our seniors? Because the concern is, if it's too early, does the immunity run out when you get to January or February? What is your experience telling you?
Flu vaccinations become available normally at the end of September and into October. We usually recommend that patients receive them as soon as possible because it takes some time for them to become effective. Flu season normally lasts until around February to March, and the flu vaccine will protect patients for the majority of that flu season.
They came available in August. It's controversial. You don't have, because of COVID-19, I mean, we're throwing everything in the air and it's difficult. There's not a lot of guidance, but I told my patients that was a little bit too soon, unless they were planning on getting another one, because yes, it takes 2 weeks more or less to get immunity, but then when it comes January, February, they're not going to have any, Of course, now it's a moot point. Get it and get it now. But back in August, I was like, I think this is too early. So I encourage them to get it end of September, beginning of October, right now. Now is the best time, in my opinion, but it's just an internal medicine opinion.
So Dr. Sharp, let me follow up with you on that. Go ahead, Dr. Hadley, sorry.
I was going to say one exception to a flu vaccine would be in seniors who are traveling, because in the Southern Hemisphere, their flu season is different than ours in the Northern Hemisphere. And so if someone knows that they will be traveling in the future, always be sure to check with your physician about vaccines that would be appropriate for that place.
Mm-hmm.
So Dr. Sharp, I was gonna follow up with you about the high dose flu vaccine. I know that a few years ago they came up with this high dose vaccine for the seniors. Mm-hmm. Can you tell us why that was done? There's been some talk about maybe it was done because people were asking to take 2 vaccines, one in the beginning of the season and one in the end of the season. Was that the reason, or are there other reasons why?
Well, the reason was that they thought that, from what I recall, mind you, I haven't done research in this lately, but it was that elderly people immunity is a little bit weaker. So if we give them a bigger boost, then they will get the response that is required. At the beginning, I was cautious because the cost was 3 times the original one, and I did not see a lot of data. But now I have seen data saying that the elderly people in the higher level of vaccination have gotten less hospitalizations, which would be the ultimate goal, right? The pneumonias or the complications of the flu. So while before I was more cautious about telling people to jump into this, now I am telling my patients that if they have multiple comorbidities, diabetes, hypertension, whatever, then that would put them at risk of doing poorly from the flu, that they should go ahead and get the high dose flu.
Thank you. So I have a sort of a general question, maybe somebody can jump in and explain. So what is wrong when your stomach gets upset every single time you eat? And I think they mean, they get diarrhea and other gastrointestinal symptoms. What can be wrong when that happens?
Okay. Many things could potentially be wrong. And so I would recommend that person contact their doctor.
Sure. But are there common conditions? And the one thing I keep hearing on radio all the time is this endocrine insufficiency of the pancreas or something. There's a lot of advertisement these days on radio about that. Is that something that's common, or is that something that the manufacturer of those medications just pushing on radio?
It is not common, but it's seen. And I can see what they're trying to do. They're trying to get an awareness. And it's true because when it comes to bowel movements and patterns of your gastrointestinal system, a lot of people are like, I don't want to talk about poop, but it is part of you, that's something that they want to empower you to talk. When it comes to whenever you eat, it could be so many things, from gallbladder to a intestine that is not getting enough blood flow. Honestly, the stomach is like a big black box, and for us, it's where we have to put our Sherlock Holmes hat and try to figure it out. It usually is not a simple, like you have pain with urination, you urinate on a cup, I look at the urine, hey, you have infection. That is nice, right? Everything was going to be like that, everybody would be a doctor, right? This one takes a little bit of thinking and more diving in, so simple like that is like back pain. It could be so many things. Same thing with that. It could be a lot of things. Like doctor said, go see your doctor, but be prepared to talk about your bowel movements and tell them, color, consistency, all those important details that we need to know.
So while we're on the topic of bowel movements and diarrhea, there's another question. So if somebody has diarrhea almost every day or every other day, what could be the problem? What are some common things that can do that?
Well, anywhere from a food allergy. For example, we're the only animals that continue to drink milk after the age of 2. So 30% of the American public is lactose intolerant. It can be gallbladder again. It is difficult without looking at the person to say, oh, I know exactly what that is. We would need more information.
Right. And again, usually when we do this in person, we remind folks that some of these questions are very hard to answer because the doctor has to evaluate what your individual situation is. Because generally, I work in public health. I could say, oh, it could be an intestinal infection. There's a lot of things that can go wrong. So yes, you're absolutely right. They're very, very hard. And like Dr. Hadley said, first recommendation would be go see your doctor. Don't ignore it, because it could be a telltale sign of many things. And it's hard. We could spend all day going through what could possibly be wrong, and we could all be wrong. It could be something totally different. So you're absolutely right. Okay, so what are the chances of contracting shingles as we age? And maybe Dr. Sharp, you want to maybe start with how shingles works, and why do we see it in seniors, and is there a higher risk as you age?
Okay. So shingles is chickenpox that you had when you were a child or a younger person, and the body sweeps it and hides it in a nerve and keeps it there in check for years. And then for reasons that we don't quite know, it could be any form of stress, an infection, or COVID-19. I've never seen so many shingles like I have had in the last few months, will release the virus in the distribution of the nerve that it's been hiding, okay? So the difference between chickenpox, which is all over, and shingles is that shingles tends to be on one side only, unless you have something that Dr. Ghabach is treating, one side only, and they can be anything from just a rash, blistering, and it is usually in crops, and it can be very, very painful, and because the nerve can be damaged. And so chickenpox hides, comes back, then it's called shingles. The virus itself, it's weakened. So it'd be hard for you to get chickenpox from it, but it has been recorded for somebody who has never had chickenpox. So if I have shingles, I would want to stay away from somebody who has never had chicken pox and its immune system is weakened, okay? And thank goodness there is now vaccines that are available. The last one is a series of 2 separated by 2 to 6 months that empower your immune system to try to keep that virus back in that nerve and not come back out.
Thank you. So Dr. Hadley, I'm going to try to punt a question to you, and if others want to join in, they're welcome. But the question is about muscular dystrophy, and if there is a way to maintain your muscle and not lose it because you have muscular dystrophy.
Muscular dystrophy is normally a disease that is inherited from our parents, and unfortunately, it's a really tragic disease where muscle strength is lost over time. Other than working with other professionals like physical therapists to improve coordination and strength, there are no cures at this point in time that can make a person regain the strength they had as a child. It's a very sad disease that hopefully in time we'll have better treatments for.
Thank you. Dr. Ghabach, I have a question related to fat cell cancer. So are there treatments for fat cell cancer? And just out of my curiosity, is it a common illness to have fat cell cancer?
I'm sorry, Dr. Tanejah.
So the question was regarding fat cell cancer. Are there any treatments for fat cell cancer? And my follow-up was, is it a common cancer that we see?
And we're talking fat cell, F-A-T?
Yes, sir.
Okay.
Fat cell.
Okay. So there's a variety of things that are labeled under fat cells cancer. These could be benign conditions like lipomas, which are just unusual growth of fat cells in the body that usually do not spread and stay localized to one area. But they could be more serious condition like something called liposarcoma, which is a more aggressive form of cancer that can spread and go to other parts of the body. So lipomas are fairly common. So we see it fairly commonly. Somebody will have a nodule under the skin. It's usually rubbery. It usually doesn't increase with size quickly. Liposarcomas are more life-threatening and more serious. So the lipomas
So what kind of treatment? Go ahead.
So lipomas, usually if they're bothersome, then you can remove them surgically. Liposarcoma, there's several varieties and several grades in them. These could require surgery, could require chemotherapy or radiation, or a combination of all three, depending on the location and the aggressiveness of the tumor. And if I may go back to the discussion on flu vaccines, because that's really important for patients who are, for cancer patients who are not on active treatment, it is important that they get their flu vaccine, whether through their PCP or through their cancer doctors. For patients who are receiving active treatment for cancer, especially if they're receiving chemotherapy, they'll need to talk to their oncologist about the timing of the flu vaccination. What we'd worry about is some patients are on immunosuppressant medication, and if we give them the vaccine where their immune system is suppressed, they're not going to mount a good response to the vaccine. So the vaccine might not be effective. That's why for patients who are on active treatment for cancer, please talk to your oncologist before getting your flu vaccine to make sure you're getting it at a time period where it's going to be effective and protective for you.
Thanks for covering that, because automatically a lot of people assume, we get this every day in the public health department, oh, I have such and such condition, I'm not going to take the flu vaccine because I'm going to get the flu from the vaccine. And you clarify the reason. It's not that they're going to get sick from the flu vaccine, it's that their immune system is suppressed and they might not get a good response, so the timing is important. So the flu shot is a kill the vaccine. It does not give people the flu. That's just such a common misconception that people have every year, and we try to correct it, but once a myth gets old, it's hard to kind of get around it.
Correct.
Okay, so I have a couple more questions, and I know we got about 10 minutes of time left. So let me ask you this, and I know this is more of a cardiology question, but maybe anyone, if you can venture a little bit of information. How long on average will a heart bypass graft last? Is it good for 10 years, 20 years, 30 years? You know, talking to your colleagues, what do you know?
There's no expiration date on a cardiac bypass that I know of. The question is, how good are you going to be with your second chance, right? So I think that the person that goes ahead and does the lifestyle changes and does the medications as prescribed by the cardiologist, usually you're going to be on a cholesterol lowering medication. You're going to be on drugs like beta blockers or whatever. So if you do all those things, it should last longer. Mind you, the veins and the bypasses are not as good as your original issued heart, right? But if you take care of the work done by somebody else, it should last some time, you know. But there is no number, no averages.
Yeah, absolutely. So I have a different question, and maybe Dr. Sharp, you can help answer. We had a GI specialist. I wish they had this question earlier in the panel. But the question is related to ulcerative colitis. A person was diagnosed in 1983, and recently, over the last month or so, they've had a flare-up, and they have high calprotectin levels, but they're negative for COVID and C. diff and all these other tests. And they're allergic to NSAIDs, the common anti-inflammatory medications. So what are some alternative treatment options that could be available to such a person?
So the treatment for ulcerative colitis, is that? So they're using some biologics. Mesalamine, it's your NSAID. It's going to be your kind of like GI steroid that they normally use. So there's the GI steroids. There are some biologics that they're using. I mean, there's new stuff all the time. You need to talk to your gastroenterologist, you know.
Yeah, you know, the previous panel we had one and we didn't have a question for that person. So it's how it goes.
Also remember that people with ulcerative colitis are at risk for cancer of the colon. I mean, I punt to Dr. Ghabach, but you know, hello, you need to be in conversation with your gastroenterologist because you are at risk, you know, not just of flare-ups, but of long-term problems. So, okay, I'll be quiet, but you need to see your gastroenterologist.
Absolutely. I think that's the best advice. Go see your gastroenterologist because it's not as easy as it may seem. There can be other issues that can be brought up because your intestine is inflamed. So questions for Dr. Hadley maybe related to injury prevention, right? You know, you're expert doctor with seniors, and injuries related to falls are a big problem with the senior population. In your experience, what advice would you give a senior on how to prevent fall-related injuries?
The person who asked the question is correct. Falls are a source of many injuries in the elderly. Thankfully, they're a preventable source of injuries. So patients can do many things in their own homes to help protect themselves. The injuries that are most dangerous resulting from falls normally are fractures as well as head injuries, which can include bleeding around the brain, which is a very serious problem. To prevent falls, we normally use what we call a multifactorial approach, which is looking at the whole person. We will evaluate the patient physically, mentally, as well as emotionally, because even things like depression increase the risk of falls. And then we will make a plan based on what we find. Sometimes things as simple as getting eyeglasses or better shoes can make a difference. Other things that really make a difference are being careful about what's in the house. Are the cords picked up off the ground? Is there a loose rug? patients tend to especially fall in the bathroom. So is there a bar that can be placed around the bathtub or around the toilet to help prevent falls? Exercise and balance is critical. Both of those are critical to preventing falls. And again, involving other experts like physical therapists can make an enormous difference because they can work with patients to help them get stronger as well as improve their balance. One program I would recommend to everyone in the community, which is throughout Tarrant County, is a program called A Matter of Balance. It's a free program that's available to anyone, including patients who speak Spanish, and they provide classes as well as training in how to prevent falls.
Yeah, thanks for bringing that program up.
Also say medication.
Health department. Yeah, go ahead.
Okay. Yeah, it's a great program. Medications are also another source of falls. So when you see your doctor, expect your doctor to do a detailed review of your medicines if you've had a fall.
Yeah, I was going to say the health department actually helped launch that program several years ago, and we've had just a tremendous interest in our community. A lot of our community partners are now providing that program. So we kind of scaled away into other things because there's so many other people that have just started providing that educational program as a matter of balance. It's a great tool. It's a very fun class to attend. So if you're looking for something to do, A Matter of Balance is a great program to go attend, and it's usually very helpful. The feedback has been great. I have one other question. Somebody asked that they have puffy fluid-filled pads at the base of their fingers and hard rope-like cords going from the fingers to their wrist. Is there anything that can be done about that?
It could be some like Dupuytren's contractions. So sometimes, again, not seeing the hand, you can inject them with a steroid. A hand surgeon is usually who we would send somebody to. It's a little bit different from the trigger fingers, but without seeing the hand, again, it's kind of hard, but you're describing a hardness, like a ropey in the palms of the hands. See a hand surgeon. And if I can add to the falls, I tell patients that there are some medications that you've been on all your life, right? And you didn't have side effects. But the liver ages, and there's medications that we don't give little kids, right? And then we give them when people get older, where now you're on the back side of the hill, and now we got to remove those medications that you've been on, but now you're not going to have a good response to, like Benadryl can make you where your balance is off. Benadryl, that's over the counter. Why should that be an issue? Or that sleeping pill that you just love and you can't sleep without, and then you get up in the middle of the night and you fall and you break the hip, So those things, people have to be open to realize that as they age, there are some things that now are not good for them, that were okay in the past. Now we need to drop off because of an aging liver, aging eyes, aging balance, so just even an over-the-counter medication can tip them over, or some of our prescription medications that we've been giving to help them with pain, anxiety, those medications now need to be removed. And then I also tell my patients, especially the children, when they come, to get on their knees and like the same exam that we parents do for toddlers, look at everything at that knee, level. And if you can fall, trip, not see, then take it off, or put like the night lights that we use for little ones. Those motion activated night lights are great, especially on the way to the bathroom, because as we get older, we can't hold the urine all night long, right? And so now we're groggy because we took Benadryl to help me sleep, that Tylenol PM, and then you are groggy, you can't see, there's a rug, there's a cat, there is something, you trip and fall, and next thing you know, you're in the hospital. So, those are things that if you do a little common sense, maybe you can avoid.
Thank you. And I have one follow-up question, and then we're almost at our time. It's related to hands again. So how do you relieve arthritis in your hands? What are some common treatments that are available? And I know arthritis can be a variety of different things, but let's just say common arthritis, the old age osteoarthritis. What do you do with that? Dr. Sharp, if you don't mind just, helping us through, because I'm sure you get a lot of those in your practice.
I know. It's just so difficult because every day in Facebook or some social media, you're going to get somebody taking collagen. What was it before? It was shark. There's always something. And there is a lot of fake science out there. But then there's things that can help. Now, I just read turmeric was helpful, but it was not in the hands, it was in the knees. So sometimes what helps the bigger joints do not help the smaller joints like the hands. Sometimes a splint in the hand. Some people wear gloves. Does it have to be copper? I don't know. There's not a lot of good science behind that. Anti-inflammatories, but you got to use those be careful because they go through the liver, they go through the kidneys, your kidneys age. Tylenol, again, you have to be careful because if you take Tylenol for your hands and Tylenol for your cold and Tylenol to help you sleep in that Tylenol PM, you may be taking a lot of Tylenol and it might not be good for your liver. Again,
complicated world.
Yes, talk to your doctor, and it should
That's right. That's the key message. Yeah.
And make sure that when you go to your doctor, you take all the things that you take. Because one time recently I had to send somebody to a hematologist because they were just bleeding, right? And come to find out they were on ginkgo biloba, vitamin E, fish oil, and Plavix. Okay, I knew about the Plavix, but I didn't know about these other stuff, which all of them cause thinning. And but the patient didn't tell me. Thank goodness, told the hematologist, and we were able to say, okay, well, maybe you shouldn't be taking that, and the Plavix. So, it needs to be a team approach. And we're not good at mind reading. Please let us know what you're doing at home.
Well, we're at our time, and I know we could have these conversations all day long. So thank you for taking the time out of your day. All three of you, Dr. Ghabach, Dr. Sharp, and Dr. Hadley, we enjoyed having you here today. This session was recorded, so it will be up on the website for those who could not attend. But we appreciate you joining us, and hopefully next year we'll see you in person.